So I'm going to talk about current indications for management of type B aortic dissections. These are my disclosures. So let's start with some definitions. Traditionally, we've classified them using the DeBakey and Stanford classification. And more commonly used is the Stanford classification, which is a type A or a type B dissection. So a type being tear is distal to the subclavian origin. More recently, in 2020, the SVS and STS came up with a new classification, which is based on the location of the primary anterior tear and the extent of the longitudinal dissection. So primary anterior tear in zone 1 to 11 is classified as a type B dissection. So the way it's done is, say there's a tear in zone 3 and there's retrograde extension of the hematoma into the left carotid, and then it extends further distally to the left common carotid. That would be a type B 210. Type B dissections are further classified based on the chronicity. This reflects the maturation of the dissection flap, which in turn will help with your treatment plan. So a hyperacute dissection is less than 24 hours. Acute is anywhere from 1 to 14 days. Subacute, 15 to 90 days. And anything beyond 90 days is a chronic dissection. So patients who present with rupture or malperfusion are classified as complicated dissections. Those without any malperfusion or rupture are uncomplicated. And then there's this third category, which are considered high risk, where they have certain features which increase their likelihood of late complications, such as refractory hypertension, refractory pain, radiographic findings such as true lumen diameter greater than 22, aortic diameter greater than 40. And we'll go into more detail later on. So who to treat? I like schematics. This is from the ACC guidelines, and again, we will go into it one by one. So the current guidelines, all of the guidelines, the ACC, the European, the SVS, STS guidelines, all of them say the initial therapy should be optimal medical therapy for all incoming type B dissections. Complicated dissections, so those with rupture, signs of malperfusion need urgent intervention, and this is based on class 1 evidence. And then both the European and the SVS STS guidelines have this other recommendation for the high risk that we talked about, where they recommend considering TVAR to treat those. And all of the guidelines, the first line of therapy, the recommendation is a TVAR. So let's deal with the easy one, complicated. So patients that present with rupture or malperfusion. Most of the patients who present with frank rupture rarely make it to the hospital. The morbidity and mortality is really high. So anybody who presents with a contained rupture or what we call impending rupture needs emergent intervention. Patients that present with malperfusion of the renals, the viscerals, lower extremity, these patients require urgent or emergent intervention. Malperfusion is caused by these dissection flaps, which can be static. So if the dissection extends from the aorta into the branch vessel, the false lumen can thrombose in the branch vessel and cause narrowing or occlusion of that branch vessel. There's a dynamic dissection where the false lumen is pressurized, so it pushes the dissection flap during systole, and this intermittently either occludes or reduces the flow into the branch vessel. And some of them can be dynamic as well as static. So all of these patients, which is about 20% of all type B dissections, generally will need intervention. Uncomplicated type B dissection, traditionally the treatment for these dissection has been optimal medical therapy, which is anti-impulse therapy, bring the blood pressure down below 120/80, heart rate below 70. So the initial therapy is usually alpha or beta blockers, and then eventually when they're stable, they can be converted to ACE inhibitors, ARBs, or calcium channel blockers. However, the reason this slide is so busy is there's extensive research that's been done shows that there is a trend towards optimum medical therapy and TVAR. So the most commonly talked about trials are the INSTEAD XL or the ADSORB. The INSTEAD showed patients were randomized to medical therapy and medical therapy with TVAR. And what they found was that at 5 years, there was increased or improved aortic-specific survival as well as delayed progression of aortic disease. Same thing with the ADSORB. They found that at 1 year, the covered portion of the aorta had a higher likelihood of thrombosing the false lumen, so delayed degeneration. And most of these patients who are at a high risk, so say refractory pain, refractory hypertension, readmissions, these are the ones, the uncomplicated patients that have a higher propensity for later degeneration and should be considered for a TVAR. Especially patients with radiographic features or morphological features such as the primary entry tear on the greater curve, shorter distance of the entry tear from the left subclavian, aortic diameter over 40, initial false lumen, true lumen diameter of less than 22, and the number of fenestrations, the size of the fenestrations. These patients will degenerate later and so should be considered for a TVAR in the earlier phase, or should be considered for early intervention. So again, like I said, most guidelines will recommend TVAR as the first line of therapy. We have gotten away from open surgery in type B dissections. So when do we treat? The SVS and STE guidelines recommend delaying the treatment beyond 24 hours up to 90 days. Again, several studies looking at what is the optimal time for treatment. The Virtue study randomized patients to acute, subacute, and chronic, and they found that acute and subacute had similar remodeling of the aorta. So, and then another paper by Miari showed that in the hyperacute phase, the patient had a higher mortality rate. So essentially, what it all comes down to, all of these papers that are littered on this screen, that in a hyperacute phase, only treat the complicated dissection that absolutely needs surgery, and leave the uncomplicated plus or minus high-risk features for the subacute phase, which is from 14 days to 90 days. And in this period, it basically is about how pliable the dissection flap is. In this phase, this dissection flap is still pliable enough that when you put up a TVAR, it's going to move and promote aortic remodeling later. So treatment methods: cover the proximal entry tear, cover any large fenestrations if possible. Again, the length of coverage depends on reducing your risk of spinal cord ischemia. Resolve the malperfusion if there is any, and again, induce favorable long-term aortic remodeling, which is true lumen expansion, false lumen thrombosis, and stabilization of the total aortic diameter. And always fall forward. These patients are going to need reintervention eventually, so plan for that when you're doing your initial repair. The first line of therapy is a TVAR. So incising the TVAR, minimal oversizing is recommended. Upsizing is more than 10% is a higher risk of retrograde type A dissections. When you're sizing the TVAR, you measure the total diameter or of the native aorta. So upsizing it or oversizing it increases the risk for retrograde type A dissections, like I said, and also stent-induced new entry tears. And the incidence of SINE is as high as 25%. And the other thing is also, I try to avoid landing in this curve of the aorta where the graft, as you know, is going to push against it, and that is generally the area where you see these new entry tears. Length of coverage, cover the primary entry tear, cover any distal large fenestration that might be there. Again, take into consideration that you need to not cover too much to increase the risk of spinal cord ischemia. And one such paper showed that zone 4 or 5 had the higher risk of spinal cord ischemia, 6% to 12%. These are the several endografts that are available for treatment of type B dissections, the Gore tag, and more recently the TBE, where you can maintain perfusion to the left subclavian artery, the Terumo Relay, Valiant, Cook TX2 and Alpha, and generally most of them are pretty good. I have used Gore and Cook are the most commonly used that I use. And, it just depends on trackability, the size of the access, and things like that on which I choose. So a couple of techniques. The Knickerbocker technique is, again, when you cover the entry tear, but you still have retrograde flow into the false lumen through the distal tear or the reentry tear. And in order to prevent that, one technique is the Knickerbocker, where you use a compliant balloon and angioplasty the mid portion of the endograft. By that, you prevent the retrograde flow into the false lumen, thereby thrombosing the false lumen, and hopefully it remodels better. The most commonly used technique these days is the petticoat technique, which is a covered endograft for the entry tear, and then distally extended with a bare metal stent across the visceral segment and into the infrarenal aorta. So this helps promote true lumen expansion, promotes positive aortic remodeling. You can cross the visceral segment, but there's still flow into the branches. And this also allows, like I said, fall forward, allows for future reinterventions if needed. This has been the most studied. More recently, we have the Cook Zenith dissection system. And both the stable 1 and 2 trials with this system showed that patients had decreased 30-day mortality with the petticoat technique. Complete false lumen thrombosis was increased in these patients. False lumen regression was improved in these patients, and then there was true lumen expansion. The stabilized technique. This is what I most commonly use, and I think this, in my opinion, is what helps the most. So you do the same technique as the petticoat technique, but instead of the bare metal stents in the petticoat technique is you use the passive force, outward force of the bare metal stents to expand the true lumen. But in the stabilized technique, you take a compliant balloon and you balloon that segment. So that way you're pushing the flap over and increasing the true lumen size. However, there is a risk of rupture in these cases, so you have to be very careful. Another one is the embolization of the false lumen. I have used this only in chronic dissections, but essentially what you do is you plug the reentry in flow into the false lumen and thrombose the false lumen that way. So management of the LSA, I just thought I would just put it up there. Most of these times that the reentry tear, the primary tear is close to the left subclavian, you need a better seal. So you end up covering the left subclavian artery. And both the SVS and the European guidelines recommend revascularizing the left subclavian. This reduces the incidence of spinal cord ischemia and or stroke. There isn't any class 1 data or randomized trials for this, but there is enough evidence to suggest that, revascularize the left subclavian when necessary. And again, with the TBE, that becomes much easier. So for my type B dissections, most of the time I generally end up using the TBE and then further extending down with bare metal stents, which is the Cook dissection stents. So one last thing is the chronic type B dissections. Indications for repair are aneurysmal dilation, 55 to 60 millimeters, rate of increase greater than 10 millimeters per year, and if they have symptoms such as pain or malperfusion. Chronic dissections are harder to fix. Generally, they are better off with open surgery. However, as we all know, those are not the most nice surgeries to perform and always have increased morbidity associated with them. So there are several things people do which are all off-label, and but the takeaway is TVAR is not just a TVAR is not sufficient to fix these chronic dissections because the flap is thickened, it's not going to be as mobile, so it's not going to move over, and you're always going to have flow into the false lumen. So Conclusions, complicated dissections, treat them. Uncomplicated dissections with high-risk features, consider treating them. Timing of the intervention, obviously in complicated dissections, it's urgent or emergent, and in uncomplicated dissections, wait for the subacute period. The goal of treatment is to cover the entry tear, promote aortic remodeling. If there is malperfusion, you have to treat the malperfusion. Consider using the bare metal stents. I think that's the way to go to promote remodeling and preserve the LSA when possible. Thank you.
Thank you, Dr. Sharif.